session, and it is on workforce planning for a resilient NHS, data, demand, and demographics. A truly resilient NHS starts with a foundational truth. Our health service is only as strong as the workforce supporting it. But as we look at the reality of healthcare today, the ground beneath us is shifting. We are facing an aging population with increasingly complex, multi-morbid needs. Patient demand is rising exponentially, and the traditional reactive ways we used to plan our staffing are no longer enough to keep pace. To future-proof the NHS, we have to move away from short-term crisis management and transition toward intelligent, proactive workforce design. This means embracing smarter strategies that are driven by advanced predictive data, shaped by the distinct realities of local communities and built for long-term sustainability. Today, we are joined by a fantastic panel of NHS workforce leaders, data analysts, policy experts, and frontline clinicians. And together, we're going to explore how demographic trends and population data can map out better staffing models, how predictive analytics can help us get ahead of demand, and how we can balance big national frameworks with the vital flexibility needed for local pace-based planning. No pressure then, guys. That was quite a build-up. And do you know what? What I've loved about today is I feel this is going to be the perfect ending. This panel is definitely the best for it. So first up, we've got Bertha Benasco Asante. She is clinical practice educator, Imperial College Healthcare NHS Trust. Welcome, Bertha. Thank you very much for joining us. Hello? Can you hear us okay, Bertha? Is there?
Yes, I can. Can you hear me?
I can hear you perfectly. Thank you. We've got Angus Wallace, his friend of the online conferences. Hello, Angus, again. Chair and Executive Director of UK Digital Health and Care. So thank you, Angus, for joining us once again. We have Tandy Kuana, Safer Staffing and PCREF Transformational Lead at Cambridgeshire and Peterborough NHS Foundation Trust. Welcome, Tandy. Thank you so much for joining us. Thank you. And last but not least, we've got Tina Fitzsimmons, AHP Faculty Lead for Cambridge and Peterborough at NHS Central East ICB. Welcome, Tina. You guys have got very long titles of your job descriptions. Thank you very much. It's Cambridgeshire and Peterborough. That's got to be one of the longest ones. Right. Well, I think this is going to be a fantastic, as I said earlier, fantastic ending for today's panels, because we talked at the start, we talked about recruitment, what's going on right at the moment. We've talked about retention. How do we keep staff? We've talked about burnout. And now we're talking about future-proofing. And I dare say it, and I'm going to go around the panel because I really want to know your thoughts on what are we in a good position for staff recruitment, and let's give it 5 to 10 years in the future. So let's talk about 2030, 2035. Are we in a good place to make sure the NHS is going to be getting that workforce right? And I'm going to start with Tandy first.
Wow.
Sorry, Tandy, really good. In there right to the start of the big one. Sorry.
That's a really good question. I think you've rightly mentioned that we have the data, and when we look at historically how the NHS has been staffed, it's cyclical. So we go through these phases where we have more staff than the vacancies that we need for their level. So if I'm to speak to the current situation now, we've got newly qualified nurses who are out of jobs, but we've got vacancies in the NHS. But the vacancies are looking at people with experience.
Right.
So there's something about how we plan for the future workforce. So we know if we're just going to look at neighborhood health that's coming, that there's been a 23% increase in demand for mental health nurses between 2022 and 2025. So in my role as Safer Staffing Lead, I look at historically in the last 6 months, what have we been doing? I look at patient outcomes, I look at workforce matrices, and then I use our mHost and Safer Staffing tools. But they tell me what's happened in the last 6 months, with the hope that I can predict how much our staffing establishment for the next 6 months. But where we are right now, that's not good enough. We need to be thinking 5, 10 years and be planning way ahead, not just for the next winter or for the next summer. So I think there's something about how we use our data to plan, look at our demography, look at the complexities of our patients, especially after COVID, and start planning for our workforce.
Is this a new concept to now start to look at 5 to 10 years in the future? I feel like we've always just, like you said, Tandy, it's been like the next winter or the next summer. But this is, I feel like this is the first time in probably NHS times, where however long it's been going, it's like actually we need to look 5, 10 years in the future. It's always been kind of reactive, hasn't it? And this now it's getting quite serious, isn't it? Tina, I'm going to pass to you and say, like, this is actually quite a serious thing that we need to do now, isn't it?
Yeah, definitely. And I think you touched the nail on the head there, that it's about that planning. And I think with the medium-term planning frameworks that have come out, and a lot of the ICB fundings are now looking at that like 3 to 5 year term plan rather than the kind of 1 year planning cycle. And that's with a lot of roles in kind of leadership, workforce and retention. They've often been very short-lived. So you'll do that piece of work where you'll get the support workforce, up and skilled, but then no one will carry it on. So that has been the challenge. So hopefully with this kind of introduction of some new frameworks, that will improve those things. And like you say, it is very much about that challenge of how we get the next future workforce in within allied health. We've overprescribed on physiotherapy, but we're underprescribed in prosthetics and orthotics, got a 35% vacancy rate. So it's about raising awareness of those small but really vital professions that are out there that a lot of school age children, you touched on it earlier, won't know about. So how do we get that awareness, increase that activity, and kind of those other things out there that aren't maybe the doctors, the nurses, midwives, physios and the OTs that we all know about. It's about those other ones that are still vital to making sure that the NHS functions. And I think that's really important moving forwards.
Bertha, to me, it seems like there just needs to be some practical strategies. It's very easy to go like, these big, 5, 10 year plans. But sometimes it's a little bit simple. It can be quite simple, couldn't it? If you got any ideas of like, how do we, are there just some practical strategies that we can implement to make it easier for the NHS?
Yeah, as we look at it now, at the moment, the NMC register, it shows that like every 1 in 4 professional is internationally recruited or educated. There are different ways that we look at it, and even the NHS workforce, like 1 in 5 is trained outside. And I believe that we have different ways that we've been filling in the gap, like apprenticeship, and other ways, like as a clinical practice educator, we've been filling in encouraging staff to upgrade from healthcare assistant to upgrade to become registered staff, apprenticeship, and the rest. But I believe that it's what goes on afterwards. Recruitment can fill in the gap, but retention is what we really, really need to pay attention to. Culture, improving the culture, and ensuring that those that we get in, they feel safe, secured, supported to stay in. There are different means, but I agree with Tandy that we've got some newly qualified staff that are out of job, and we still have vacancies. We're not recruiting. That is one thing that we need to talk about as well. And I believe that staff don't come in only because they want job, but they want to feel safe and they want to feel part of it. They want to feel part of the team to be able to deliver the quality work that they need to do.
It's crazy, isn't it? Angus, going to bring you in here because it from an outsider, from most, the common sense seems to go away when it comes to to this. And okay, so do we need to change the way we need to look at it? Maybe make it a bit more exciting, dynamic. Do we do it enough? I don't know. What are your thoughts here? Because I know we've had lots of conversations about, this. And do you feel that they're doing enough to make sure that we're future-proofing our staff for the future?
No, I think there is a lot of work to be done, Gail, and it's not minor tweaks. It is major changes. And one of the things that is very noticeable is the fact that NHS employers across the board are not supporting a job that is family friendly.
Yeah.
They've got to make the jobs more family friendly. Let me give you an example.
Yeah.
Our medical students who are just qualifying have to apply for foundation year posts. They have to apply throughout the country. They may not hear when their foundation year post is until 2 weeks before they are appointed.
Angus, can you just adjust your microphone a little bit? You're a little bit muffled.
Okay.
So you're a little bit.
Oh,
speak. Go for it.
Why didn't you come back to me?
Okay. All right. No worries. Yes, and I think that's absolutely right. And I think we talk about the world is changing, isn't it? So we don't have the lifestyle as we did before. Things are, adapting. We live in 2026 now. 2030 is going to look a little bit different. 2035 is going to look a little bit different. So Tandy, are the NHS realizing this? Are they aware that we've got to adapt for this? Are they ready to? Do they want to adapt? Because I think I've said this about 5 times today. If you always do what you always did, you'll always get what you'll always got. So, what doesn't make. I'm baffled, but then it's I'm the host. So, Tandy, are the NHS? Do they know this? Should I go and tell them what's the roles are going to have to change, aren't they?
Yeah, and to be fair, the NHS has been trying, because I know from my previous roles, new roles have been introduced. We're trying to, so from a safe staffing point, we are required to have a workforce plan that will detail how we're going to recruit, retain, and reform the workforce. I think the challenge is, how do we put that into practice? So we know that we need intergenerational workforce planning. What works for Gen Z might not work for a different generation, for the millennials. And if we're flexible enough and we co-design the workforce plans with staff, we stand a greater chance of retaining them. Currently, we have a one size fits all model, and it doesn't work. And as I look at the newly qualified nurses that are coming through, they're more bolder, they're more courageous, and they know what they want. They're not worried about security, they want the flexibility. And then we also have our over 55 workforce who want some sort of flexibility. They also want professional development. So a one size fits all doesn't work. So we need to be brave and do things slightly differently, from our rostering, from how we utilize our leave, from how we utilize our whole headroom. So it just requires us, I think, to put people first before processes, and look at what's best for the workforce. Because if the workforce is happy, our clinical outcomes are better.
Exactly. And it's using that data as well. We collected all this data. We collected, obviously, got the demographics as well. And it's using that. I feel like it's like a bit, I feel like, oh gosh, my paper's all flying around. It's like, I feel like a bit of a minority report, bit of this, bit of that, adapt it around here and twist it around. And then we can then actually say, well, this is going to be the right workforce for the NHS. And it's going to be something that we've never, ever seen before. But that's okay. That's quite exciting, isn't it? We're going to have, like I say, it should be brilliant. We're going to have this incredibly diverse workforce. We've got in different pockets what's needed. We're going to have like some that are going to need more this care. I think it's quite exciting. Tina, are you feeling the excitement, or is it just me?
No, I do. I think the population health focus for a lot of the strategic commissioning moving forward is really important. So, like you say, we can target that healthcare to where it will have most impact and value and where it's most needed. And like it's been touched on before, what you might need in a heavily dense populated demographic to a rural and coastal is going to be a totally different skill set. So it's about trying to focus the workforce on the skills that they need depending on where they're working, rather than we just need a set process and standard. So it's about having that flexibility and the competence and confidence of our staff and trusting them. I think trust is a massive factor in trying to upskill workforce and delegating responsibility. And I think that's a really important part moving forwards as well, how we build that into our plans.
Definitely. And I feel like this, it's one size fits all. It's just got to go. Totally. This is now. I'm getting annoyed with it because it doesn't work like that. And when you see these, the recruitments, it doesn't work. I don't understand how we can have vacancies but qualified staff. In my mind, it doesn't work. Bertha, come in. We need to listen to the frontline staff more, don't we? We need to get their opinions and say, like, right, what do we need and how is this going to future-proof the workforce?
Yeah, for me, looking at my role, I speak from where I stand and where my experience is. I'm a clinical practice educator. The staff that come into my department, I've become like a doorway. They come through me, I induct them, I've got time with them. And from that experience, I've noticed that creating the space, it doesn't matter whether Gen Z or Gen Alpha or Gen, I believe baby boomer, I believe that recruitment opens doors, but belonging gives people a reason to stay. We have to think about the environment, how we can make staff feel feel part of the team, to stay to do the work. If we invest in our people, in our staff, can you hear me well? Is it? Oh, am I
No, it's all good.
too loud?
No, you're all good. All good, Bertha.
Okay, yeah. Retention is built through relationships, not contracts. It is simply about creating environments where people want to remain. For me, I believe that if we create an environment, a culture that our staff working, because we normally base things on the systems, policies, protocols. As a professional nurse advocate, that I conduct regularly. Clinical supervision, RCS, restorative one, just creating the safe space for staff to be able to come and speak and get their voice heard. They are willing to stay, not because they have a job, because they can be heard. They are listened to, they are valued, the culture sustains them, they are supported. So I believe we need to look into that, how we can get all generations, the younger ones, the new ones, the older ones, how they can all feel satisfied to stay on. We need to invest in the people, not more in the systems and processes and policies, and forget that they work through the people.
Yeah, agree. Angus, let's see if we can hear you now. Angus?
I'm back on a different mic, okay?
That's it. Are we perfect now, Angus? There's the Angus going, love.
Let me go back to where I was. We were talking about foundation year doctors, often appointed less than a month before they have to take up post. And of course, nowadays, in order to do that, you have to find accommodation. In the old days, you got hospital accommodation temporarily. They have to find accommodation, and they can be anywhere around the country. And I think that is very unkind. I do think that we need to rethink exactly how we use doctors during their junior years. If you look at private hospitals, you go into a private hospital, you're looked after throughout the day, throughout the night, and you're looked after very well.
Yeah.
There are no foundation year doctors there. When foundation year doctors were introduced in 2005, they were introduced because of the European Working Time Directive. And part of the incentive was they didn't have enough young doctors to man the hospitals at night, every night, because they insisted on having a most junior doctor on call in the wards at night. And therefore, they have produced a system which I do not believe now fulfills what doctors need. And I think the foundation years need to be revisited. And I think the whole way that wards in hospital work needs to be replanned from the medical staffing point of view. So I think there is a lot of work to be done. We cannot continue to move over the next 5 to 10 years without that sort of reorganization.
I know, and I completely agree. And I know your opinion that there's a selection process, recruitment process, or there's so many barriers when you know, for entry, and there's just like obstacles here and there. Angus, I would love to change it, and I would love to make it easier, because I think this is a lot that people are, you know, it's time and time again going, well, I couldn't apply for that job because I'm not in the right bands, and then this happens, and then this happens, and then I haven't got training for that, and I've promised this. And we go around in circles, don't we, Angus? And this is the frustration, and it doesn't need to be like this, surely.
Once you get into the main training posts above foundation year, it becomes better organized.
Okay.
So I wouldn't like to criticize across the board, but it is the lower levels that do need to be revisited, in my view.
Yeah, I know. It's crazy, isn't it? But we also need to, we've talked today as well as about really promoting the NHS and bringing up the fantastic staff that are involved. And we've talked about going into schools and just actually saying, look, how brilliant it is. But, you know, obviously the negative stuff comes out, and, you know, the burnout stories, and, you know, and one thing that came out was about psychological safety as well, has come out a lot today. And obviously, Tandy, you're in safer staffing. How do we make sure that this is not something that a lot the future workforce that's kind of in the back of their heads going, well, I've heard this about the NHS, I heard there's bullying, I heard there's toxic culture, I heard, you know, that I'm not listened to. We need to work on this as well now, don't we, Tandy? Because otherwise we're never going to attract the staff that we really, really want.
Yeah. So I think it was in this month that the NHS introduced the workforce standards. So they are going to be looking at leadership, anti-racism, professional development, and the rating will affect the national oversight framework. So clinically, if you're performing well, but your staff are telling us something different, then your national oversight framework score will be affected. So I think we're heading in the right direction. And what I would say, I think, to most of the chief execs out there or anyone in senior leadership, is to look at the iceberg of ignorance. And what it tells us is 4% chief exec know 4% of what's happening in their trust, and it goes down levels. And the people who know what's exactly going on, the staff on the shop floor. So there's something about visible leadership. There's something about talking to staff and not having royal visits. Whenever I get the chance, I say to senior members of staff, royal visits are not good enough. Just going and waving and people saying you were here. Immerse yourself in the work. And we see that with some of the most successful chief execs in the NHS. They do shifts. They allow themselves to be part of the workforce and to experience the discomfort of working when you're short staffed, to experience the fear in mental health of working when you don't have enough staff that are trained in physical restraint. So I think it goes back to, are we listening to staff?
Yeah.
And in safer staffing, we triangulate. So we look at sickness rates, we look at supervision rates, and more now we're starting to look at culture. The CareCup report told us about culture and how it affects staffing and how it feels. And more importantly, something I've been passionate about is how our systems are so fragmented that we're losing nursing time on different systems. So you've got system one, then you've got Rio. So you're recording clinical outputs on different systems. And if my memory serves me right, I think we lose about 12 hours a week.
What? It's supposed to be helping. It's supposed to be
Yes.
saving
So
time, not
technology is a good thing
Yes.
for us, but I always cringe when new technology is introduced and nurses are not part of the journey. Like now we've got AI, everyone's talking about AI and how we can use AI, but no one's looked at the digital literacy for nurses. We're nurses, we're not tech people. So take us along when you're introducing any new technology so that when we go back and we're working, we're not going to lose patient time on technology.
Well, Angus, you are very passionate about this, aren't you, Angus? You've got to bring the staff on the journey. You can't just say, "Da-da, we're going to do this," and look how shiny this thing is, and everyone's just like, "Yeah, well, thanks for that," you know. And you hear that 12 hours are lost. It's like, no, that's not the way it's supposed to do.
I'm really passionate about it, and thanks for bringing it up, Tandy. And the thing that I was most impressed with changing technology was what has happened at Leicester and Peterborough, where the Will Monaghan, who has been installing the new patient record system, before he did that, went round the hospital observing the problems that people were having, not just doctors, but nurses, physiotherapists, a whole lot. He took all that in and he has tried to adjust the introduction of the new technology to make their lives easier. Yeah. But there are problems, Gail. Everybody tells you ambient voice technology when you are having a conversation with patients and it is recorded, saves a lot of time. It does save time, but the person who is responsible for the communication has to double check it before it goes into the hospital case notes. Yeah. And that takes time. So it's not a total savior. It is saving some time, but it's creating an additional job for the clinician or the nurse to do.
Oh, it's just crazy, isn't it? It is. But these are the conversations we need, isn't it? The reality is really like the leadership to go, instead of them just going, "Oh, we've got this," and they're frontline staff and the ones that go, "Well, actually, you're actually doing this, this, and this." And until we get this right, and this is what I'm feeling, and we've only got a couple of minutes, so we need to sort of start wrapping it up. But if we don't get this right, the basics right, I feel, how can we future-proof the best workforce in the NHS? Because right now I feel like we're in a bit of maybe a transition. Would I say, was that the best way, Bertha? Am I saying transition? We're in a bit of a bleh. Yeah. And unless we get this sorted, how can we start getting the most amazing resilient workforce in 5-10 years?
Yeah, that's right. When it comes to technology aspect, from my point of view, it's got the good side and the downfalls as well. And they've mentioned, a lot about it. From my experience with staff, new staff trying to fit into the system, different systems, different operation, different data systems, even in operating theatre, for data collection and also documenting staff and patient documenting the systems that we use. We've got staff that struggle sometimes. That alone, they come to say, I can't handle this and I want to quit. It takes individuality, trying to look at the staff, what they need, listening to them. I believe regular huddles and hearing it from the staff point of view really helps. If I can touch on professional integration, cultural adaptation, because I deal with a lot of international recruits, and me myself coming in as an experienced nurse 24 years ago, feeling that you know it all, but then there are new systems you're going to have to work with that you are completely ignorant about, or you don't know what systems have we put in place to be able to ensure that the staff that we've recruited are prepared very well. So I created a PPP, Professional Progression Pathway, from internationally educated healthcare professionals to be able to go through cultural adaptation, professional integration, and prepare them from their individuality, what they need specifically, so that they can fit in without feeling out of space.
Love it. I love that, Beth, and please keep up that amazing work. We are running out of time, so I'm going to just hand over to Tina for the last word. You are the fire. I know, no pressure, Tina. I'm going to say, right, if you could implement one change tomorrow that could strengthen the workforce planning across the NHS and future-proof it, is there something that springs to mind for you? Maybe there might not just be one thing, there might be a few things. But
I was going to say that's a big question, isn't it? For one word, that was a loaded question. I think it's about sharing the purpose and vision. So you've got to bring people along on the journey. So the best change management, the best leadership, the change of culture is taken one conversation at a time. And if you can have a decent conversation with someone that influences a pathway or a workforce, then you're doing the right thing. And that's probably it's those little wins every day that will then build up to that big culture change. I think that's probably it.
Yeah, and we do it in sport, those little 1%, and it might not seem a lot of the time, but when you look back over a few years, you've actually climbed a mountain, you've actually changed quite a lot. And I think this is something that I think today has been a really, really big message, that these 1% do matter, do need to be implemented, and they will make a change for the future. And you might not seem it, and you might be like, oh, it's just some little thing. It does matter. And if it does mean going back to basics, the basics are important as well. And like you say, everyone said about bringing everyone on the journey, feel included, feel valued, because otherwise, what's the point? That's what it's about and what it should be. So, there is no NHS without the workforce. So recruitment, retention, well-being, leadership, they are all part of the same system. We've said the challenge is significant, but it's shown today that the insight, experience, and commitment to address it already exists with our wonderful people that we have in there, and we've seen that in our speakers. And of course, the next step is action. Please take these conversations back into your organizations, your teams, your leadership, and turn them into meaningful change. That's what these conferences are about. So thank you once again for all of our speakers, and to Tina, to Tandy, to Angus and Bertha for our final panel as well. And more importantly, thank you to everyone here for all the work that you do within the NHS workforce.